So now I request Dr. Anasua Ganguly Kapoor to talk on ocular surface squamous neoplasia. So she practices ocular oncology at KVC campus of LV Prasad Eye Institute, Vijayawada.
Yeah, thank you, Swati. So, in the next few minutes, I will be talking on topical fluorouracil versus interferon in the treatment of ocular surface squamous neoplasia. I have no financial interest to disclose. So, talking of the two most commonly used pharmacological options in OSSN, interferon alpha 2B and 5-fluorouracil, which one is better? So, let's find out. So, interferon alpha 2B is a recombinant glycoprotein, a cytokine with anti-neoplastic and antiviral properties. So, the mode of action is it improves the T cell mediated immune response and also inhibits angiogenesis, whereas 5-fluorouracil is an antimetabolite. It inhibits non-competitively the thymidylate synthase, which interrupts the DNA and RNA synthesis in the rapidly proliferating tumor cells of OSSN. So when can we choose these agents to treat OSSN? So these days it is the primary treatment modality pharmacotherapy for OSSN. So it's basically an effective alternative to surgery, what we call as immunotherapy or a chemotherapy. So it can be used as an adjuvant to surgical excision, what we call as immune or chemo reduction or prevention. I will come to that. And for treating recurrences. So what do we mean by immunoreduction? When we have an extensive OSSN with basal diameter of more than 15 millimeter or more than 6 clock hours of involvement, we need to reduce the size, or for that matter, many of these cases just goes away with the treatment, with the use of chemotherapeutic or immunotherapeutic modalities. But these are absolute cases where you can't go ahead and do a surgical excision because we will end up with a lot of limbal stem cell deficiency. So immunotherapy is specifically for corneal OSSNs. For this particular case where you see there is a sheath of cells on the corneal surface, here you can't go ahead and do a excision biopsy, and these cases respond very well to this pharmacological therapies. And for recurrences, immunoprevention is when histopathology, so when you have excised lesion, histopathology shows margin positivity, we go ahead and treat these patients with these pharmacological modalities for a period of around 3 months. So moving on to the reconstitution of the drug, it is fairly simple for both interferon alpha 2B and 5-fluorouracil. So interferon is usually available as 3 million international unit or 5 million international unit as pre-filled syringes. From there we reconstitute and make 1 million international unit eye drop with using lubricants or distilled water as diluents. Similarly for 5-fluorouracil, it is extremely easy. 1% aqueous solution we make, 1 ml of 5-FU we mix with 4 ml of sterile water. Administration, interferon alpha 2B, as we all know, 4 times a day, and there's no drug holiday. Whereas for 5-fluorouracil, there's a drug holiday. We use it for 1 week and then pause it for the next 3 weeks. But for the injection, interferon alpha 2B, you can, what we usually prefer, but it differs from different, from different locations, the dosage use differs, but what we use in our institute is once a month, whenever required, not in all cases. So the advantages of injection include direct delivery to the tumor site, more rapid tumor resolution, and ensured compliance. And 5-FU, as we discussed, there's a 3 weeks drug holiday. So again, moving on to the storage, the cold chain maintenance is important for interferon alpha 2B to give stability to the drug. So we need to store it in the door of the fridge, and also the cold chain needs to be maintained while we are transferring the drug, giving to the patient. So what we usually do is we give it in a thermocol box with ice packs in it to maintain the temperature between 2 to 8 degree. But as you can understand, for patients from a low socioeconomic background, like for farmers and all, maintaining the cold chain itself is a difficulty. So there 5-fluorouracil stands out because we need not keep it inside the fridge. Moving on to the outcomes with both interferon and 5-fluorouracil. So response rate for interferon has been differently stated from 80 to 100%, with a mean resolution time of around 4 months and a recurrence rate of around 8%. Whereas 5-fluorouracil, the response rate in different studies have been differently quoted, but we recently looked into our patients in LV Prasad Eye Institute in the Indian subset, and we found the response rate to be 88% with just primary 5-FU therapy. The rest, 12%, required some additional treatment for complete resolution. The mean resolution time was around 2 months, which is again a quicker resolution compared to interferon alpha 2b. The recurrence rates were also comparable, 7 to 10%, but in our study we got it around 2% at 6 months follow-up. Moving on to the adverse effects, interferon has mild and transient adverse effects like conjunctival hyperemia, ocular irritation, superficial punctate keratopathy, follicular conjunctivitis reported as less than 5%, whereas 5-fluorouracil, again the complication rate is around 7 to 10%, and similar, most commonly being conjunctival hyperemia and sterile keratitis, some lid edema, punctal stenosis. But what we usually see in these patients is that that the conjunctival hyperemia usually comes down during the drug holiday period. So for the injectable interferon alpha 2b, the flu-like syndrome with myalgia, fever is reported, again with less than 10% of cases. So here, but all of them are mild and transient, the side effect profile. For 5-fluorouracil, punctal stenosis, and this is how usually we see there is some amount of redness seen in these patients. Moving on to the drug cost, again interferon is not very costly, but one vial costs around 800 rupees, whereas one ampule of 5-fluorouracil costs around 11 rupees, and from one ampule multiple vials can be made, so the reconstituted drug cost comes to around 2 rupees. So 5-fluorouracil is much cheaper compared to interferon alpha 2b. So it is important while we are discussing about pharmacological options for treating OSSN to understand when not to consider these immuno and chemotherapy whenever the diagnosis is in doubt. So these days we really don't go ahead and do a incision biopsy for all cases, but whenever the diagnosis is in doubt, it is good that we just go ahead and do some incision biopsy, establish the diagnosis, and then go ahead with pharmacotherapy. Whenever the depth of involvement, we need to understand that these are options only when there is no involvement of the sclera or there is no intraocular extension of the OSSN. Whenever there is a adjacent structure involvement, we can't use these pharmacological therapy. So whenever the depth is in doubt, better not to use them. And like the T3 stage involvement of the adjacent structures, intraocular, cornea, fornix, tarsus, punctum, lid, best not to consider. Patient compliance is extremely important whenever we are giving pharmacotherapy. The patient needs to come back every month, so it's best to discuss with your patient at the time of starting the therapy. And if the patient is not ready to come back, best to go ahead and excise. And we see many patients are routinely getting pharmacotherapy post-surgery. That is not what is required. We only advocate use of pharmacotherapy post a wide excision only when the margin is positive, not in all cases. So just to summarize what we just discussed. So both interferon alpha 2b and 5-fluorouracil, the reconstitution is easy. Both are effective with low rates of recurrence, but interferon has the best ocular surface tolerability, so it is the side effect profile is a little less compared to 5-fluorouracil, and the injection option is also available, which directly can be delivered to the tumor site and ensures compliance. Whereas 5-fluorouracil, the drug holiday is something with less frequency of administration, which is helpful to the patient. There is no storage problems as we see in interferon. A cold chain needs to be maintained there. It is cheaper compared to interferon, and the response is quicker. So considering all these facts, we need to be prudent while choosing which pharmacotherapy to use, the tumor characteristic, the patient profile, the ease of follow-up, availability of the drug, the burden of cost, all these needs to be considered before we decide on the treatment modality of choice for a particular patient. These are my references. I will acknowledge both my colleague Kavya and Swati for all help they extend in my practice. Thank you everyone for a patient listening.